Picture this. You're in a completely slammed emergency department. A patient rolls in with a spiking fever, a nasty cough, and they're really struggling to breathe. Right away, the first diagnostic tool you're probably reaching for is the chest x-ray. It's an absolutely indispensable frontline tool for us. But here's the thing. Reading these films accurately while you're under the gun, that is a massive challenge. So in this explainer, we are going to crack the code on pneumonia x-ray patterns, and we'll figure out exactly how to tell the difference between typical and atypical infections. Let's get into it. So the big question we really need to answer is, how on earth do emergency doctors spot the exact cause of pneumonia on a simple black and white x-ray? I mean, it kind of feels like looking for a needle in a haystack of gray shadows, right? Well, it turns out different microbes actually leave very distinct fingerprints behind on the lung tissue. And today, we're going to learn exactly how to spot them. Here's a quick look at our roadmap for today. We'll start off by identifying what pneumonia actually looks like on film, then contrast your typical bacterial patterns with the atypical and viral ones. After that, we'll hunt down some classic radiological signs, talk about the pitfalls you've absolutely got to watch out for, and then bring it all home with our key ED takeaways. All right, let's kick things off with our first topic and establish a baseline. Before we can play detective and figure out what specific bug is causing an infection, we have to know what an infection actually looks like. And that all comes down to one absolutely crucial word: consolidation. This is the cornerstone of pneumonia imaging. So what is it? Consolidation is just airspace opacification. Think about your alveoli, those tiny little air sacs in your lungs. Normally, they should be full of dark, radiolucent air. But with pneumonia, they get totally gunked up. They fill with fluid, pus, or cellular debris. On an X-ray, all that gunk turns those nice, dark areas into dense, cloudy, white patches. Notice how perfectly this summarizes the basic radiological feature of pneumonia. It's simply one or more areas of consolidation. And, this can be anything from a tiny fuzzy patch all the way up to a massive whiteout taking over an entire lobe of the lung. It's also worth noting that this consolidation can sometimes show up alongside a loss of lung volume, something you'll actually see quite a bit in pediatric patients. Moving right along, let's talk about typical bacterial patterns. Okay, let's line up our first group of microscopic suspects. What do classic bacterial infections actually do to the lung's architecture? Well, the data tells us lobar consolidation is the heavy hitter here. It's the most common finding by far, showing up in over 55% of community-acquired pneumonia cases. When you see a dense, homogeneous whiteout that is strictly confined to a single lobe or segment, that's a massive red flag for a bacterial culprit. Usually, you're looking at Streptococcus pneumonia or Klebsiella pneumonia. You might also notice the infiltrates progressing really quickly or spot pleural effusions larger than 10 millimeters. Oh, and if you see cavitation, where the lung tissue is literally necrotizing and forming a hollow cavity, that's a huge clue pointing to a bacterial etiology, very often Staphylococcus aureus. Now, let's flip the script and look at atypical and viral patterns. We need to draw a really sharp contrast here, because this is vital in a fast-paced ED. While bacterial pneumonia hits you with that dense focal lobar consolidation we just talked about, viral pneumonia behaves in a completely different way. Viruses, like H1N1 for instance, typically present with bilateral, diffuse, interstitial, or reticular patterns. So instead of one solid white lobe, you're looking at a patchy ground glass appearance that spreads diffusely across both lungs. And usually you'll see minimal to no pleural effusion. It's a very different visual signature. But you gotta stay on your toes because atypical pathogens love to break the rules. Take Mycoplasma pneumonia. You'd probably expect an atypical bug to look like a virus, right? Actually, the data shows it often presents with patchy or confluent consolidation. And here's the real curveball. It is remarkably unilateral. In 69% of cases, it affects just one side of the chest, often localizing to just a single lobe. Pretty wild, right? All right, on to the really fun stuff. Let's break down some classic radiological signs. This is where we look at those specific radiological fingerprints that give us those aha moments. Just look at the bulging fissure sign here. Notice how the consolidation in the right upper lobe is literally pushing the minor fissure downward? That is a classic textbook hallmark of Klebsiella pneumonia. What's happening anatomically is the infection produces such a massive amount of heavy inflammatory exudate that it physically weighs down the lung lobe, bulging that fissure right out of its normal place. Now, check this out. See that clear, flat, horizontal line right in the middle of the cavity? That's your air fluid level sign. And because it has an equal length on orthogonal views, meaning it looks exactly the same whether you're looking at a posterior, anterior, or lateral chest x-ray, it strongly indicates a spherical lung abscess. This is a massive clue. It screams severe necrotizing infection, often pointing the finger straight at Staphylococcus aureus or anaerobic bacteria. And there are a few other highly specific clues you definitely want to keep in your back pocket. The silhouette sign is a great one. It's when you lose that normal lung soft tissue interface. So say you can no longer clearly see the right heart border, that tells you exactly where the infection is hiding, right there in the middle lobe. Then you have air bronchograms, which are 96% specific for an airspace process. There's also the crazy paving sign you'll see on CT scans. It's this crazy mix of ground glass opacity and smooth septal thickening, and it can point to anything from a severe viral infection to pneumocystis pneumonia in immunocompromised patients. But wait, it's not all perfectly clear-cut. Let's talk about pitfalls and diagnostic limitations. Okay, time for a bit of a plot twist. We've seen how incredible imaging can be, but we have to ground this explainer in reality and talk about why we can't always trust our own eyes. Take a look at this number, because honestly, it's a bit of a shocker. 27 to 35%. That is the overall specificity of pulmonary opacities for pneumonia. What does that actually mean for us in the ED? It means if you spot a white opacity on a chest x-ray, roughly 2/3 of the time, it's not actually pneumonia. The image alone is dangerously nonspecific. To make matters trickier, a completely normal chest film absolutely does not rule out pneumonia. In the first 24 to 48 hours of the disease, an x-ray can look perfectly clear. On top of that, infiltrates can totally hide in patients who are dehydrated or neutropenic. You've also got elderly patients who might be sitting there with acute, life-threatening pneumonia, but zero clear early signs on their imaging. And let's be real about ED logistics for a second. Those portable chest films we take quickly at the bedside, they actually miss up to 26% of infiltrates that you'd easily spot on a CT scan. So here is the absolutely crucial takeaway. You are looking at shadows. And unfortunately, a lot of different things cast the exact same shadows. There are numerous severe non-infectious conditions that can easily masquerade as an infection on film. Atelectasis, which is lung collapse, asymmetric pulmonary edema, or even a pulmonary hemorrhage can all mimic the whiteouts of pneumonia perfectly. You simply cannot diagnose in a vacuum based on the film alone. Let's wrap things up with a summary and our key takeaways. All right, let's bring all this evidence together for a final debrief. Here is your ultimate ED protocol, distilled right from the sources. Step 1, try to identify the pattern. Is it a dense lobar consolidation pointing to bacteria, or a diffuse interstitial pattern hinting at a virus? Step 2, scan for those classic clues, your bulging fissures, air fluid levels, and silhouette signs. Step 3, and this is arguably the most important, correlate clinically. Always pair the image with the patient's vitals. Are they running a fever? Is their heart rate over 100? Respiratory rate over 24? And finally, the golden rule of the ED. Never delay empiric antibiotics while you're waiting for imaging or culture results if you strongly suspect a bacterial infection. So, as we close out this explainer, I want to leave you with a provocative question to chew on. If the x-ray comes back looking perfectly clear, but the patient sitting right in front of you has a high fever, a rapid heart rate, and a terrible productive cough, what's your next move? Well, the answer lies in everything we just talked about today. The biggest lesson here is that you always have to treat the patient, not just the picture. Thanks so much for joining me for this explainer, and remember to always look beyond the shadows.